So I've been interested in policy responses to health inequalities in the UK for the last 20 years or so. So that's what I'm going to be speaking about. I'm going to be drawing on a range of different research projects, and along the way, there've been lots of different people that have input to that. So particularly with the citizens juries research that I'm going to speak about towards the end of the talk. And I just wanted to acknowledge, I won't read all the names. I just wanted to acknowledge all of those and the Leverhulme funding that supported that project at the start. So yeah, in my career, I've had two linked interests. So one is the relationship between evidence and policy, and trying to understand who influences policies that impact on public health, how they influence them and why. I started off focusing on how evidence particularly influenced policy. That shifted to a focus on ideas for reasons that I'll talk about. And then because ideas can be shaped by so many different interests, that then broaden out to focus on institutions, external actors and so on. And then alongside that, I've got a substantive interest in health inequalities. So that's where my main publications lie. And this talk is obviously sitting at that intersection. So we've had health inequalities, very extensive health inequalities in the UK for a long time. And I'm sure you're all familiar with headlines like this, which seem as if they just keep coming every few months, that the situation around health inequalities is getting worse, it's widening, various different factors appear in media headlines at times. Austerity it's been linked to a recent widening of health inequalities and a decline in life expectancy. COVID has shone a light on inequalities by ethnicity, which have been understudied in the UK up until this point. We've traditionally focused on socioeconomic and place-based inequalities. So there's no shortage of headlines. And with some of those headlines and the fact that they're repeated over time has come this concern that policy activity in this area, policy attempts to try to reduce health inequalities, might constitute, in this, to quote this BBC News headline, wasted money. So there was a report in England that was making this point, and there was also an Audit Scotland report in Scotland that made a very, very similar point around 10 years ago. So there's concern that if all this policy effort has gone into reducing health inequalities and we've still got widening health inequalities, do those investments make sense? Can we justify continuing to try and reduce these health gaps? And it's also obviously led to a lot of disappointment in the health inequalities research community. Richard Horton, editor of The Lancet, is making this point here. Johan Mackenbach, who's done a lot of international comparisons, has also made a similar point. So Horton says here, the defeat of inequality is an important goal of public health. But although there is a broad consensus, especially since health inequalities are deepening, little progress is being made in creating that elusively fairer society. Experts in health inequalities have successfully drawn attention to the social determinants of health, but the explanatory power of social determinants has not fully translated into an actionable manifesto. That disappointing reality should be inviting some difficult questions about what inequalities mean to our society, why advocacy for their defeat has failed, and what we should be doing differently in light of these failures. And it's those kinds of questions that a lot of my research has been really trying to get at. So that's what I'm interested in understanding. When I first started out doing this research, I was focusing on the period of new Labour governments in Scotland and England. And I'm not going to go into lots of detail about that, right? It was quite a while ago. But what I wanted to use this slide for is just to flag the vast amount of policy activity that was happening at that time. So this slide is just focusing on national level policy activity around health inequalities and just in England. And you can see that across this period, there's a host of developments. Some are led by the Department of Health, some are led by other departments, some are cross-cutting, but there's no shortage of activity and of statements saying that the government takes health inequalities seriously and wants to reduce health inequalities. That's continued under most governments, and it is also the case in the devolved nation. So we're not short of policy action. And we're also not short of evidence that's examining the problem of health inequalities. So my early PhD and postdoc research were examining, okay, so if we've got all of this evidence on health inequalities, and we've got these strong policy commitments to reducing health inequalities and to taking an evidence-based approach to health policy, why aren't we having more success? And one of the key findings that I got to with that analysis, that it might not be surprising to many people, right? But I'd focused initially very much on evidence. What does the evidence say? Because at the time there was a strong focus on evidence-based policy. And what I found in looking at the data was that it wasn't really evidence that was traveling into policy, but ideas that were informed by evidence. And that's like quite a subtle distinction, but it's important because ideas are much more malleable, right? So they can change much more easily than evidence as they move into policy. And some of the ideas that I noticed having changed. So ideas around lifestyle behaviours and the role of health services didn't have, so their role in health inequalities in the UK, not particularly well supported by research evidence, but strongly evident in policy. Whereas ideas around material structural change were strongly evident in the research literature from the Black Report onwards. They were also strongly evident in policy rhetoric. So a lot of policy rhetoric, but they kind of got stuck there. They weren't translating through to much policy action. And then psychosocial ideas, which I'd associate with Michaelmas and Richard Wilkinson and Kate Pickett. So the ideas that inequalities in society are bad for people, partly because of how they impact on people psychosocially, concerns around status and so on. So these ideas, which Richard Wilkinson and Kate Pickett and Michaelmas are all firmly kind of linked to income inequalities, had got fractured as they travelled into policy. And what I mean by that is only certain bits of these ideas had travelled into policy and other bits had got left behind. So I remember talking to a really senior civil servant in the Scottish government, really senior, and he was telling me how exciting he found these ideas about psychosocial determinants of health inequalities, and how exciting he found Richard Wilkinson and Kate Pickett's work. And he had some of their work on his shelf and he was drawing a diagram to me. And what he said to me was that what their work showed was that there was no strong relationship between income inequalities and health inequalities, which is basically the opposite to what I think they think their work is saying. So what had happened was the idea that psychosocial feelings and things like stress and status and confidence and so on, those factors, or the idea that they're important for health inequalities, that had travelled into policy, right? But the link to income inequalities and wealth inequalities had not. That had sort of got left behind. This is just a table that's kind of summarizing those different journeys. It goes into a little bit more detail, but it kind of showing, like, sort of in a very simplistic way, what was my analysis trying to do? Look at whether these ideas were supported by research evidence, then look at whether they were evident in the policies at the time. And so if we understand it as a marketplace of ideas around health inequalities, rather than focusing on specific bits of the evidence jigsaw, then it becomes important to understand who's articulating ideas, how and why, and how those ideas change as they travel into policy. So I'm now going to talk through 6 factors which I felt strongly shaped the translation of ideas about health inequalities as they moved from research into policy. So the first is that policymaking bodies are set up in a particular way. So this is drawing on institutional theories, right? And I particularly like Vivian Schmidt's discursive institutionalism. This, to me, seemed to capture what was going on. So in both England and Scotland, the bits of the policymaking body that were responsible for health inequalities were based in health departments or directorates. And those departments and directorates were divided into teams that basically reflected a medical model of health. So there were teams focusing on diet and physical activity, teams focusing on smoking, teams focusing on cancer, and so on, right? You see a very medical model that's been institutionalized. And this then operates as a filter. So this civil servant's describing, so I'm asking them about to what extent civil servants are able to identify and access research evidence. And they're saying, well, people don't go traipsing through professional journals, they mean academic journals, but you do have specialists within the department as well. So for example, on diet and physical activity, there is a diet coordinator and there is a physical activity coordinator who is specialists in their own right. And in addition to that, you have specialists in terms of doctors and things like that, many of whom actually do spend a bit of time with the journals. And so what you see here is that the people who are spending time looking at the research evidence have very specific focuses within this kind of broader health policy context. So they are focusing on things like particular diseases, particular risk factors, and particular population groups. So that works really well for some kinds of evidence, some kinds of issues like tobacco control, say, and it works much less well for a cross-cutting issue like health inequalities, which not only cuts across different population groups and different health issues, but also is linked to this idea of social determinants, which are policy levers that sit in completely different departments and are really hard for the people sitting in health to have an impact on. So that means that you've set the policymaking organisations at that time were set up in a way that was basically filtering out the more cross-cutting social ideas about health. There's also a lack of institutional memory within many policy-making organisations. This one chimes with the news today. So this senior academic saying, what's really struck me is we seem to do the same bits of work over and over again, you know. So this is an academic, right, who does a lot of work closely with government. A demand will come in for something, and because I don't keep copies of these things, I think, oh, we've done that before, and then someone else will dig it out. So on Monday, we're doing a piece of work which I know we did 2 years ago, but everybody's changed, so nobody knows that's what we did 2 years ago. And I think this is important, right, because it allows a sense in which there's an ongoing conversation between researchers and policymakers. It allows a sense of continuous conversation, but that often that conversation doesn't really feel like it's progressing anywhere. It's just going around in a similar repetitive cycle too often. And then the third is the role of research funding in shaping research activities. So I was surprised how much this came up at the time. So this was kind of a pre the impact agenda really taking off. And people were still talking very much about trying to read the policy signals and ensure that their research funding applications spoke to those signals. So this senior academic saying, you get questions in a purely scientific sense, you get questions that you want to pursue. So what do? You hang it on one way or another, you hang it on some issue that you think will get it funded. And then they gave an example of an idea that they'd had that they felt was too critical of government policy to get funded. So they reframed it in a way that would work more with the current policy trajectory. And then this senior academic a bit more explicitly saying, I think one of the difficulties is often that when there are bids for research funding, it's almost as if the findings or, you know, the messages that are required are stated from the start almost. And when one looks at research bids, there are strong steers in terms of what they're looking for, what kinds of conclusions one's being steered towards, what kinds of policy messages they want. And the point here is that regardless of how accurate that is, academics felt that was accurate. So they were responding to that. So they were trying to look at these policy signals, as they say, and then thinking about what research they thought was likely to get funded based on those signals. And that came up more for researchers who were closer to policymakers. So researchers who were working in research organizations that had some kind of funding directly from government, or researchers that did a lot of consultancy work. They talked about this more than researchers that were more at a distance. So the researchers that were interacting with the system more seemed to feel this pressure more. So that means the research that's being done, the questions that are being asked, are informed by researchers' readings of the policy system and policy trajectories. And I'm making a brief aside here because I was really interested in this, and I was also interested in a repeated critique that policymakers made of researchers, which is that they weren't clear enough about the kinds of policy changes they thought needed to happen. So I undertook a survey of researchers working on health inequalities in the UK with my colleague Moore, and we basically asked researchers to be really we pulled together a list. I think we had about 100 different policy proposals that we pulled together from Marmot Review and various other reviews that we could identify in the literature that were making specific policy proposals, and then we were asking people to assess these against 3 different criteria. And what that paper showed, really interestingly, I think, is that if you asked researchers to assess the strength of a policy proposal or the extent to which they agreed with the policy proposal based on their expertise, and then if you ask them to assess the same policy proposals based on their sense of the strength of the available evidence, they gave quite different answers. So when we asked them to do that based on their expertise, they often focused on the policies that they felt were more likely to reduce health inequalities were the more economic, upstream, preventative policies about changing people's living and working environments, changing their income, wealth, and so on. But when we asked them to assess the same policy proposals based on the strength of the available evidence, they shifted to focus more on downstream behavioral factors like smoking, alcohol, and so on. So that shift kind of speaks to what I've just spoken about, which is the sense that researchers aren't always doing the research that they think is most important, right? They're doing the research they think will get funded, or the research that does get funded. And this is important because when we, in the second stage of this survey, we gave people notional points to distribute, and so you'd give more points, more of these notional points to policy that you thought would have more impact. And what that showed was that the policies that people thought would have the most impact were the ones that aligned with their expertise. So there were these upstream economic policies. So here you see the top one with the most support is implementing more progressive systems of taxation, benefit and pensions. The second one is developing and implementing a minimum income for healthy living. And the third is increasing the overall government expenditure allocated to early years and ensuring that expenditure is focused progressively on the social gradient. Fourth is increased social protection for those on the lowest income. So, I won't go on, but they're very much economic policies, not traditional health policies. And then right at the bottom, you start to see those more lifestyle behavioural policies which was where they felt a lot of the evidence currently lies. So tobacco, alcohol, and so on. So this seems important to acknowledge. Then the fourth thing is the way in which researchers articulate their research to policy audiences once it's been done. So this is a senior academic who did a lot of work with policy organisations, was active in trying to use evidence to influence policy. And they went, for a period, they went on a placement to a kind of policy analysis organisation. And they were reflecting on that experience and saying when they were there, that I could have been much more critical. It isn't simply that I feel the funding source wouldn't like me to say those things. I actually would feel it would be a betrayal of the trust that the people who gave me the opportunity to spend my time doing that had in me. And I think in a way, when I looked, and they say this organisation was actually funded through a government department, I think they would have looked at me and said, how can you not have read what is appropriate to say? So I think the censoring is actually self-imposed. It isn't that I think they would come the heavy on me. It's that there's an unwritten understanding that I won't rock the boat when I'm writing in that guise. So at an academic event, I feel I'm me. I can be much more pointed in the points I want to make. But I think when I'm writing through a funding source, which is government, and I do it out of, and maybe I shouldn't, I do it out of a sense of loyalty to the people who are trusting me not to say things that would make them feel uncomfortable and cast into doubt the judgment that they had in saying I was the right person to do the job. So you see across this period, this sense that if you want to be influential in government, you have to be, what did one researcher put it to me, who'd moved from academia to a think tank? They said, you don't want to be seen as a ranter, someone who's ranting all the time and being critical from the sidelines all the time, right? And I love this quote because it really captures the essence of what a lot of people were saying, that you needed to be seen as someone who wouldn't rock the boat. Now, we've seen plenty of examples where government actually get rid of, and recently quite a worrying shift in the UK, in Westminster, I think, saying that you can't even have researchers, you can't invite them here if they're saying anything critical of the government. So that all of that kind of creates this sense that if you're speaking to a policy audience, you shouldn't be too critical and you've got to be careful about what you're saying. And that then changes, it has an impact on how ideas are translated, how they travel. And that process continues within policy organisations. So this is a civil servant who I was interviewing, and I was saying, what happens when you're presented with a new problem, like an urgent problem that you haven't dealt with before? And they were saying, well, if you've got a problem, the first thing you do is you work back in the files and you see what you said last time, and then to ask one another what you think you should do, and then to make a judgment about what ministers really want, what's feasible and what's politically this, that and the other. And this, I really like this quote because I also have a quote from a minister that I interviewed at the time, and he was saying to me, well, I get all this advice from civil servants and they tell me what they think I should be doing, but they never really explain that in any detail or tell me why they're giving me that advice. So basically I don't trust it, and I take advice from another couple of people that I'm friends with and that I trust in some way. So there's this really odd thing going on around where civil servants are trying to judge what ministers want to hear, but then ministers are sometimes suspicious of what civil servants are telling them because they're not sure why they're saying that. And this has been written about by senior civil servants. So a former civil servant, Lord Bancroft, said, was talking about this this being a problem, that seeing advice which ministers want to hear falls with a joyous note on their ears, and advice which they need to hear falls on their ears with a rather dismal note. Civil servants will tend to make their advice what ministers want to hear rather than what they need to hear. And so it's through these processes that I think we can start to see how certain ideas get fractured as they move from research into policy. So only certain bits of it travel, or the ideas get transformed as they move. But then the final point, and the one that I'm going to spend a little bit more time talking about, is there was this assumed lack of public support for the kinds of upstream preventative policies that most researchers seem to support if you ask them for their expert opinion. So this policy advisor interviewed in 2011 saying, even if all the evidence said we must do this, but then again, if there's a whole opinion, national public opinion saying, well, actually, no, we disagree with this approach, as an MP, you'd have to weigh that in. And then a senior academic interviewed a bit earlier. And so this is, the height of when Labour were in power. Saying we're not willing to live in societies where there's equality in other domains other than health. So we're not willing to live in societies where there's equality of wealth or equality of income, and equality of housing or equality of access to other services. In virtually every other domain of life, we don't want equality. We actually worship inequality. And of all the people I interviewed in my PhD and my postdoc in this area, evidence policy interface around health inequalities, so I interviewed 112 people across this divide. Only 8 of them claimed there was any public appetite for more egalitarian policies, and no one claimed there was much media or political interest in such policies. So there was this sense that people want to reduce health inequalities, but they don't care about other inequalities, and they're not going to support the kinds of policies that, that research suggests is required. And yet it was largely unclear what claims about the public were based on. There's been very little research to explore public understandings of health inequalities, and even less about public views on potential policy responses to health inequalities. And interviewees who referred to the public almost never linked this to specific empirical evidence. They sometimes, I did ask, and they sometimes vaguely spoke about opinion polls, sometimes British Social Attitudes Survey, but more often than not, it was the media, traditional media, but also popular programs that were seen as examples of showing that people worship inequality in some way. But nonetheless, the public were implicated as political actors who were resistant to the kinds of policy proposals emerging from the health inequalities research community. So I really like Walker and colleagues. They're talking about a different topic, right? But they talk about how the public can exist as imaginaries, given agency and invoked for strategic purposes by actors in policy debates. And this is kind of what I ended up feeling was happening with the public in debates around health inequalities. So reflecting on that, I decided to do some research to try to better understand what had actually been published and what research had been undertaken to try and understand public views of health inequalities. Now, there is some quantitative data, and in the end, I decided to focus on the qualitative insights. So what I did in this meta-ethnography with Rosie Anderson was we brought together the qualitative studies that we could find at the time, which were giving lay accounts of health inequalities. So they were giving accounts often from deprived communities, not always, but often from more disadvantaged communities, of what was impacting their health and what caused health inequalities and so on. And what that showed was that evidence at the time was limited. I've just updated this review for Scotland, right, and there's been an explosion of literature in this area in the last few years, but it hasn't changed the conclusions that we drew, really. So, and the evidence is still limited compared to the mass of other research on health inequalities. So at the time, we only identified 17 studies that had been written up as 20 publications. We didn't identify any studies asking people what kinds of policy interventions they would support to reduce health inequalities, and there has been a small number undertaken since that time. There was some overlap of methodological variation and differences in finding, but all of the in-depth qualitative studies find that public explanations of the link between socioeconomic deprivation, poorer neighbourhoods and poorer health is aligned with researchers' accounts and concerns around the social determinants of health. So there is a bit of an issue here in that quantitative survey research that asks people off the top of their head what they think about the extent of health inequalities often finds that public understanding of health inequalities is relatively limited. But all of the in-depth research that's asking people what impacts on their own health, and particularly when you start to disaggregate physical health and mental health, and you're focusing on more disadvantaged communities, all of that suggests that people have a sophisticated understanding of the factors impacting their health, and that is quite social in nature. So this is just, I tried to bring this together into some kind of diagram. Basically, this is trying to capture all of the different pathways between socioeconomic conditions and health that people described. It's obviously simplified, right? But commonly it worked that people would describe material structural conditions, so things like poor housing, unemployment, poor quality environments, and then they talk about how that had a psychosocial impact, or an impact on their mental health. So they talk about stigma, shame, stress, worry, social isolation, feeling judged, those kinds of things. And then they talk about how that impacted on decisions they made, which are around lifestyle behaviors and also material structural factors, and that those things then impacted on health. So there is this, it's simplified, right, because it was much more messy and complex than this, but this was a common kind of account of what people were describing, which is very much aligned with social determinants of health account of health inequalities. But there is a bit of a paradox, because the studies, and it wasn't all of them, but the studies that ask people to explicitly talk about health inequalities met with some resistance. So people seem more comfortable talking about how social and economic material factors impact on their health than they do in acknowledging the logical consequence of that, which is the health inequalities we have between different social groups and different places. So we reflected a bit on why that was, and several of the studies suggested, we felt quite persuasively, that it's part of an attempt to resist a sense of stigma, shame, and disempowerment. So it's really disempowering to acknowledge, if you live in a more disadvantaged community, the extent of health inequalities and what that might mean for your health and your family's health. And it's more empowering to kind of resist that and to talk about how actually individuals have quite a lot of control over their own health and so on. And it's about the choices they make. So this kind of paradox, but I think we can understand why that paradox exists. And the important thing, I feel, is that it doesn't mean that people don't understand the social determinants of health. And this is an example of the kind of stigma that I'm talking about, and why I think we need to be really careful when we think about how we want to communicate health inequalities. Some of the conclusions from quantitative survey-based research are that people don't understand how big health inequalities are, and so we need to have a big educational campaign, and we need to make people more aware of health inequalities. This extract here, which is from a paper by Vari Mackenzie and colleagues, is really stuck with me as making me think, actually, we need to be really careful about doing that kind of work. So it's a guy called John, and he's based in Scotland, right, in a deindustrialized area of Scotland. So nearly every day I'm picking this paper up, the newspaper, and I'm reading about life expectancy with me compared to maybe staying down in London. And they're absolutely kicking you in every way they can, like. And if you're in a poor area, you'll always be in a poor area. Nobody's going to try and help you out. But if you're in an affluent area, to hell with the rest. So you get this sense of like how unfair it is and how disempowering it can be. That, I mean, there were plenty of other examples. That's just one. So I wanted to then build on this and do some more research in this area to explore this paradox a little bit, but I wanted to do it in a way that didn't feel really disempowering. So we decided to focus on research that also asked people about potential solutions, potential responses to health inequalities. And we did do a representative national survey because I wanted to be able to compare our results to some of the surveys that had gone before. But the main bit of research we did used citizens' juries. So citizens' juries are deliberative group-based work that take place over at least 2 days. Ours were all 2 days, and we had one in Glasgow, one in Liverpool, one in Manchester in July 2016, right, just after the European referendum. So I was a bit nervous about these juries. So going in, it felt like we're in quite a divided place societally, and I wasn't sure how they were going to go. The juries are designed to bring together really diverse groups who have different views. So we sampled so that people were diverse by age, by gender, but also by political view and views on inequalities. And we didn't signal in advance that the citizens' juries were going to be focusing on health inequalities. And the questions that we wanted to address are set out here. So I'm not going to I won't read them all out, but those are the questions that we wanted to address through this national survey and citizens' juries. So for the nationally representative sample survey, Opinion administered it for us, and we had 1,540 nationally representative respondents, with 50 top-up respondents in the 3 cities where we were doing the citizens' juries, so that we could kind of situate our jury members' responses in relation to responses in those 3 cities. So that was the final survey of 1,717. The results suggested that around 70% of people are aware that richer people live longer, but most people don't seem to think that poorer people are more likely to experience key non-communicable diseases like heart disease, cancer, mental ill health, or accidents that underpin those health inequalities. Again, it seems slightly paradoxical, but I think we can understand why that might be. But I think it's a lot to do with what I was talking about before. Those results are remarkably similar to a survey that used similar questions that was undertaken in 1997, so like almost 20 years before. Which Sally McIntyre and colleagues wrote up, which suggests that public recognition of health inequalities, if you just use a survey type approach, hasn't increased since 1997, which seemed really odd because Labour did put a lot of emphasis on health inequalities, and there was a lot of media coverage of it, and there was a lot of policy activity. Anyway, I'm just going to give you, I'm going to focus most of the rest of the talk on what people said about potential policy responses. So we gathered together 12 policy responses, and we were informed by that earlier work that I talked about when we asked researchers which policies they thought would be most effective. And the way that these looked in the survey, just to give you a sense of it, is they appear as this kind of Likert scale. So people were asked on a scale of 1 to 5, where 1 represents strongly disagree and 5 represents strongly agree, please indicate the extent to which you believe that each of the following 12 policy proposals would reduce health inequalities. And so people are just circling a number. And we used this survey in the nationally representative sample survey, and we also used it in the citizens' juries. In the analysis, and I'll just say on the juries, we asked people to complete the questionnaire at the beginning of the juries before they'd have any conversation or heard any evidence, in the middle of the juries, at the end of the juries, and then we tried to follow it up a year later, but our response rates a year later weren't good enough to conclude much. For the analysis, we grouped proposals using, it was quite complicated to juggle looking across 12 different policy proposals. So we decided to put them into categories, and we used Whitehead's 2007 typology. We didn't have any proposals in the strengthening communities category that she has, but so some of the proposals mapped to strengthening individuals, so things that were about kind of public education campaigns around what impacts your health, the importance of giving up smoking and so on. Then there were some proposals in the improving living and working conditions, around employment conditions, living conditions, and so on. And then there were some that were about promoting healthy macro policies, so more about changing economic policies to be fairer, that kind of thing. A key finding is that most respondents supported all of the research-informed policy proposals included in the survey. I mean, maybe that's not surprising because, we weren't asking people to make trade-offs and to decide what they weren't going to fund by using public money on this. But I did find it surprising because there had been so much a belief amongst the researchers and policymakers that I'd spoken to that people didn't support these kinds of policies. So to me, it was surprising. So that example there is increasing the minimum wage. You can see majority support. And so even the policies that the researchers and the policymakers I'd interviewed were clear that people wouldn't support, such as introducing higher taxes for richer people, had a majority support. It's not as strong as the minimum wage there, but it is still strong. This table here, I've used color coding to try and, so green is indicating the strongest level of support within the national sample survey, orange is in between, and red is indicating lower support. So I think red was below 50%, orange was like 51% to 74%, I think, and then green was 75% or above. So we can see here, if you just look at the kind of colour patterning, that in the national sample survey, the kinds of policies that gained most support were in this improving living and working conditions, but they were also about spending money on the NHS. So one is spend more money on the NHS and the other is spend more money on GP services. So those were the most popular in the national sample survey. If we compare the data from the citizens' juries, so as I say, there are 3 two-day juries in these 3 cities. The full sample is 56 respondents. So we recruited 20 to each city, thinking that we'd have about 16, but 20 turned up in Glasgow, 19 in Liverpool, and 17 in Manchester. So it's quite high participation. And as I say, we asked them to complete the same questionnaire as the national survey, the beginning, the middle, and the end, to sort of track how people changed. And support was greatest by most measures for category 3 proposals, so improving living and working conditions. And you can see from this that even at the start, the citizens' juries, although we tried to sample this diversity, that there was more support for these kinds of policies, a little bit more compared to the nationally representative survey. But we see that support for some of these proposals declines a little bit in the group voting exercise that we did at the end. When it comes to strengthening individuals, so public health promotion campaigns and that kind of thing, there's quite a lot of support when you're asking jury members to look at this individually. But when we ask them to rank these in the group voting exercise at the end, they fare quite badly. And promoting healthy macro policies is kind of the opposite here. Well, I mean, it doesn't do that badly at first, but it's not as strong as strengthening individuals. And then when it comes to the final group voting exercise, quite a few of these proposals were included, as we'll see later. So this is just what the group collective voting looked like. So people were still voting individually in that everyone had stickers. And so there was 2 rounds. The way it worked was we put the policy proposals there. People would put their individual stickers on the proposal that proposals they supported. I think they had a few different, I think they had 2 stickers each. And then we'd look at it collectively and discuss it. We'd change the ranking, and then there'd be a second round of voting because people could change their mind, and then we'd rank them again collectively. So what the results were in terms of the top 5 proposals from the 3 cities are summarised here. Now, they do, in particular, in Manchester and Liverpool, maintain this focus on investing in the NHS. But aside from that, you can see that these policy proposals are quite economic in nature and quite focused on redistributive kind of policies. So very, very much, again, in line with the kinds of policies that people who I'd interviewed earlier on felt that members of the public wouldn't support. Now, there's more to say about this. It's not obviously that simple, but we also let people put forward their own proposals. So if they weren't satisfied with the proposals they were encountering in the jury that we put to them, informed by the research, they could also come up with their own proposals. And I think what's interesting about these is they didn't come up with many in category 1, just one, and they came up with a lot of policy proposals in category 3 and 4. So a lot were about improving living and working conditions and those macroeconomic policies. And then a few more insights from the qualitative data on this. And for me, this qualitative data is what I find most interesting. Okay, so if we get behind the numbers, this idea that you should provide the public with more health information, which was often discussed as health education in the juries, was very popular and didn't seem to be that contested. But if we actually look at this exchange, somebody's talking about this kind of public health promotion campaign. So a bit more education for some people. Instead of taking their kids to McDonald's and spending £10 or £15 on that, they could buy a bag of shopping, buy fresh fruit, fresh veg, go somewhere. And then the facilitator says, thanks very much. Anyone who has something on that? And another person says, I agree with that, because it talks about education, which I think is the fundamental. It's the level that you educate people. It allows them to make the right choice with whatever resources they've got. The more money that's thrown at education across the board, and the earlier it starts, education, it underpins everything else. It underpins everything we do. It informs our choices. It explains your actions. It does everything. Unless you have it, you don't really have much. And what we see here is a shift, I think, in an understanding of what this policy proposal is about. The first person's interpreting it as we had intended, a health promotion campaign. The second person is interpreting it much more generally about education, which would take it into a different category of the way we'd categorize our proposals. So there is some shifting, and everybody doesn't always interpret the policies in the way that we assumed. It's important to acknowledge. On this gap around category 2 proposals, which in Whitehead's typology is about strengthening communities. So we didn't identify anything in this area in the research literature. But it was quite a prominent topic of conversation, particularly for older members of the citizens' juries. So there were often older members of the citizens' juries that were talked about how communities used to have a really strong role in providing social support and contributing to positive things that would help build resilience against health inequalities. But it was a consistent story told across the 3 cities that these older participants would say, well, this used to be the case. But then when these large employers started closing, through the processes of deindustrialization in the 1980s and so on, that kind of sense of community fell apart or got taken apart, and now we don't have that anymore. So there's a sense here that it's important, but not many policy proposals in this area. In terms of the fact that across the juries and the survey, people continue to really support investing money in the NHS to tackle health inequalities, even though in the 2 days they heard a lot of material that was suggesting that that wasn't a key cause of health inequalities in the UK, and probably wasn't an effective way to respond to health inequalities. They did hear from a GP working in a disadvantaged area who was making a case for investing in more GP services in disadvantaged areas, and they were very persuaded by that, I think, on average. There's also this really interesting thing around the NHS, which I think, my colleague Ellen Stewart is writing a book at the moment called How Britain Loves the NHS. And there just is this emotional attachment to the NHS. And you see in some of the ways that people spoke about the NHS, they almost equated it to health. So this person says, I think the NHS is top because other than family and friends, your health is the most important thing. But it was also contested, and it's important to acknowledge, because in the quants data, it just kind of seems to be doing really well. But there were quite a few comments where people said, well, we could probably do more, but I think maybe there's more than enough there, or there's nearly enough there, but we're constantly mopping a bath that's flooding instead of turning the tap off. So there was, despite the popularity of investing in the NHS to tackle health inequalities, there was some concern about whether that was the right approach. On housing, I felt this was there were really interesting discussions around housing. It was supported by the national survey and jury members in individual questionnaires, and the jury support increased slightly over time, and it was also included in the top 10 proposals of all 3 juries in the final group voting. And you see in the jury discussions that the conversations around housing seem really persuasive. So in all 3 juries, there were people that talked about direct personal examples in either themselves or in their family of the impact that poor housing can have on health. And they were quite emotive, poignant examples, and people did seem to be affected by them and persuaded by them. And then complementing these accounts, there was also a clear articulation of the routes via which improved housing, better housing, could make a difference. So this example here, a female participant in Liverpool saying, maybe we should think about starting really from the bottom and working up. So before we provide more jobs for people, make sure that the national minimum wage is increased. And before we stop people from smoking, let's make sure that they've got more money for social housing, so they're happier. They're taking a new outlook on things to stop them from being unhealthy. And across the discussions, you see housing getting positioned as this kind of foundational element that needs to be in place before other things can happen to improve people's health. On taxes, so introducing higher taxes for rich people, again, lots of interesting discussion. So average support was below 4 in both the national survey and across the 3 time points in the jury. However, over 50% of the participants agreed or strongly agreed with this proposal, and it featured in the top 10 proposals of 2 of the juries in group voting. So it's a mixed picture. And what was interesting is that it was frequently discussed in juries, but clearly contested. So this person saying, for me, it's number 1, way before everything else. Apart from the fact that a fellow juror and I one topic we came up with was first out of the 7 proposals discussed, 6 of them were saying spend. And has anyone thought about where the money's come from? It's got to come from somewhere like that. So it was the rationale was not just because it was fair, but also because it would help fund the other things. And then someone else saying, well, if you've worked hard to get to the top, why take your wages off you and bring you down? I don't think that's right. So there's this sense that people had a fundamentally different view about what was fair or not fair, and those didn't shift much in the discussions. But there were some really interesting discussions around what counts as rich. with very divergent views, In one case, one guy in one of the juries, I think it was Glasgow, was arguing that 100,000 wasn't rich, and you know, the threshold should be higher. And in the end, the jury sort of seemed to agree with that because he was quite loud and persuasive. But in our ethnographic data, there were 3 women who were disagreeing with that. So in terms of increasing the price on unhealthy products specifically, again, there's lots of interesting conversation here, is contested. The difference between this proposal and the last one is that people really actively try to persuade their fellow participants. So they gave a kind of very clear rationale for why increasing the price on unhealthier products was a good idea. I know I'm conscious I'm running out of time, so I won't go into detail here. The final point, and it relates very much to recent news items in terms of the qualitative data, or one of the last points, is that there was a really widespread lack of trust in government at both national and local level, and it did surprise me and the rest of the research team how pervasive it was and how strongly people articulated this. So you get again and again people talking about politicians don't know what they're doing, they can't really do anything about health inequalities, they can't even run the country, so we're lost really. And then similar comments on local authorities. We couldn't run a bath, our local authority, and a particular concern around how money is spent. So the taxes that government take are stealth taxes just to get more money out of the public, and then not tell you where it goes. And we're not really a democratic society because we, the people, do not get to vote on where our tax paying goes. So this, even though there was a lot of support for the upstream policies, right, this really undermined that, because people thought that there should be, in many cases, people thought there should be higher taxes or more redistributive taxes, and there should be more investment in housing and so on. But they didn't trust the people that would need to take that action. We also did see this resistance to being stigmatized that I spoke about earlier, and as you might expect, there was some recurrent, quite individualizing, fatalistic discourses that came up, not as strongly as I expected, has to be said, but they were there, and they did push some people towards the more individual focuses. So to conclude, research to understand public views of potential responses to health inequalities, I think, is likely to vary by method and design. So there's some Q methodology studies in Scotland that reached quite different conclusions to this study. The results from asking participants to complete individual questionnaires vary between the survey sample and the jury sample, with jury members being more favourable towards more of the policies. And the individual responses from jury members shift slightly over time. So people's views do seem to be malleable to a degree. And the group voting, I think for me, that was the most interesting. Like the group voting responses are really quite different from people's individual responses. So it's the same people, but a different context. They're being asked to share those views in front of others. And perhaps, as you might expect, they then shift towards more collective policy responses, more upstream things that affect more people. The qualitative data complicate that picture further, demonstrating that one of the most popular proposals in group voting, higher taxes for richer people, was also one of the most controversial in group discussions. In contrast, a proposal that was outside of the top 10 proposals in group voting across all 3 juries, which is to provide the public with more health information, appeared relatively uncontested in jury discussions. Our results challenge, I feel, that this idea there's a lack of public support for the kinds of upstream policy proposals favoured by many researchers. And there is now, I think, some more recent quantitative data that would support that. It counters previous evidence from UK research and is also out of line with some Australian research. Nonetheless, some of the category 4 proposals, notably tax increases of any kind, generated substantial controversy within jury discussions. And our analysis suggests that's as a result of 3 intersecting factors. First, a resistance to ideas experienced by participants as disempowering, which at times included the very idea that health inequalities exist. So in all 3 juries, there were times when participants were saying, is this really the case? I really don't feel that these health inequalities can be as big as you're saying. The existence of individualistic and fatalist discourses that run counter to ideas that health inequalities can or should be reduced via upstream policy changes. So this idea that if people want to smoke, they will just smoke, and so on. And then this issue that I think is so crucial, a lack of trust in local and national governments, which partially aligned to some previous research by Lundell and colleagues, which also focus on this idea that there's a lack of trust relating to incompetence and corruption. And it's so important because I think that that does more to explain a sense that people are wary about certain policy proposals than claims that people just don't understand how these things impact on their health. So it has really important implications for those seeking to promote evidence-informed policy responses to health inequalities, because I think it suggests that work in this kind of communication advocacy area is unlikely to make much difference unless it is also thinking about these broader challenges, particularly trust in local and national governments. So thanks very much.